Hello, everyone. Thank you for standing by. Welcome to today's session, the Interoperability and Patient Access Final Rule, what health plans and healthcare providers need to know. My name is Morgan Tomko, and I will be your host for today's session.
So the agenda here should jive with the abstract that you guys saw when you registered for the webinar, but just to cover this really quickly, we're going to start with a quick overview of the intent of the regulation, right? What is CMS trying to achieve by making us all comply with the various aspects that we're going to describe today, and what beyond compliance, what goodness do we see in the outcomes we can achieve by driving these implementations. We'll level set on intent to start the conversation. We'll try and give a nice summary of what the actual rules are related to the regulation that is upon us right now. And when we do that, we'll try and provide a little bit of context. This is not the first foray that CMS and the related agencies have taken into the interoperability space, right? This rule upon us right now stands on the shoulders of some predecessor requirements that have gone live prior to the dates that are upon us now. And so we'll provide a little bit of context on some of the history that got us to where we are, what we need to be focused on and worried about getting live in production right now. And then we'll provide a little bit of context on some of the proposed rules that are already published, in proposed state for upcoming, rules related to the subject matter. So we're definitely talking specifically about, the patient access final rule, but we think it makes sense to describe that in the context of things that have come before and things that will come after. So we'll share, a little bit on that as well. We will then move into talking about, organizational value beyond pure compliance. What are some of those things that your organization can also achieve, based on the investment you might be making in getting compliant, on the specific requirements of the rule itself. How do we think about other strategic initiatives you might be able to unlock or enable based on the core work you're probably doing to bring the interoperability requirements online. And then we'll end with some, I think pretty pragmatic, maybe motherhood and apple pie is a good cliche, pragmatic considerations on how do you implement this successfully, right? It's a complicated set of requirements, but it, a lot of brass tacks and just good old fashioned project management might get you across the finish line. So we'll share some of our thoughts on, what those key enablers are to a successful implementation. All right. So we'll start off here with, a little bit of that intent conversation, and I'll take this one and then I'll kick it over to Heather and Brad to take us further into the details here. The diagram on the picture, or on the right-hand side of the page rather, we've used this in value-based care presentations before, and the goal of the picture is just sort of trying to explain, the complexity of the relationships that exist in our industry. Right, so given patient A in this case, may have had, payer A or health plan A at some point in the most recent years, providing their coverage, and, maybe they switch to payer B. If they're a, Medicare Advantage member, maybe they move from one MA plan to another, over a 2 or 3 year time horizon, and their historical information exists inside of multiple payers. Maybe they've got a primary care relationship at provider A, but they've got some specialist relationships at provider B, and they sometimes, go to the hospital at provider C, and if it's not an integrated delivery system, maybe those are all separate organizations. Meanwhile, those same provider organizations are serving patient B, and payer C is providing coverage to patient B. So we've got a whole nother, slice on the relationship complexity. And, in order for any of these organizations to have a chance to manage the people who matter in the middle of the diagram, they all only hold sort of a sliver of the information necessary to care for that patient population. And so when we've had value-based care conversations, we've had a lot of conversations about, a lot of the data sharing and technology implementation that often comes along with a value-based care, contract relationship. And we've historically had that conversation through the lens of creating, integration among the companies operating in the space. I think the cool thing about interoperability is, among others, it really focuses on putting the patient at the middle. It focuses on making all that data available about their care history and about their diagnostic history available to them, and it allows them to, share that information, with the people they participate with in their care journey, whether that's a downstream payer that they might switch relationship to, or whether it's a provider among their panel of providers that help them manage their care. By putting the patient in the middle and by turning on all these pipes that enable data to flow into the patient, we do a lot to sort of unwind that complexity of the point-to-point integration that might have previously been contemplated among organizations, and we turn it loose, through the patient. So I think that's core to the intent, right? And giving patients the ability to easily and securely access their own information, and then giving them the ability, therefore, to do something with it, right? To allow that information to flow through the system, controlled by the patient, to those who the patient decides need to have it in order to help them manage their care. So we see some really nice intent in the regulation here, and we see a technology enablement of a theme that's been building for a long time, and maybe some really positive forward traction in some of the upcoming milestones that Heather and Brad will describe to get us towards that objective. We'll talk about the details of what is mandated, what kinds of data sharing among what kinds of parties is part of the mandate. And just to clarify, right, who the mandate applies to, the regulation governs what I would simply describe as government-sponsored business lines, right? So if your organization cares for or provides coverage for members who come from one of the programs listed here, where the federal government is providing the funding for those programs, you're the one in the crosshairs for the regulation. There's obviously other business segments, in the marketplace, both those fully insured employer groups, self-funded employer plans, as two examples, right? Those guys aren't covered by the regulation at this time, but most organizations are certainly providing coverage for taking patients from across all the customer segments. So we would expect that most organizations are indeed affected by this, but down at that patient level, it's a subset of the patient population that we got affected. So hopefully that's a quick and dirty level setting that focuses mostly on intent and who is required to comply. From there, Heather, let me turn it over to you and maybe take us into a little bit more detail on what the rules actually are.
Yep, thanks, Mike. So just to level set, in a brief history of interoperability and healthcare in the United States, I think we can all acknowledge that the road to interoperability in the U.S. has been a lengthy one and is only continuing to gain momentum. Within the past decade plus, we've seen numerous initiatives to try to improve interoperability, primarily between the inception of ONC in 2004 to the introduction of the HITECH Act in 2009, which really aimed to achieve significant improvements in care through meaningful use of EHRs. Increasingly additional initiatives in the 2010s. So the 21st Century Cures Act and MACRA both mandate and encourage additional interoperability between the members' health plans and providers, and CMS 9115F, which is the Interoperability and Patient Access Final Rule, along with its companion ONC Final Rule, is really just the latest flavor that we've seen. And I'll get into the details on the Patient Access Final Rule on the next slide here, but it's showing no signs of stopping. So just to highlight one future rule that we do have coming up for many of the organizations that are on the call today, CMS did introduce a proposed rule for interoperability and prior auth in December this year that builds upon the primary components of that of the Interoperability and Patient Access Final Rule that we're really focused on as an industry right now. So for the Interoperability and Patient Access Final Rule specifically, there's really 7 main components to this rule. I think the first, just acknowledging that this is a rule that has a companion ONC interoperability final rule focused on information blocking. The final rule became final on March 9th of 2020, and many of the 7 components that will be required go into effect either already or are upcoming in the next couple of months here. I will let my colleague Brad get into a little bit more specifics on some of these, but just to name each of the policies within this rule, there are 2 specific requirements related to public reporting and information blocking, as well as digital contact information that providers will need to prepare for. CMS has indicated that they will be publicly reporting any providers that submit a no response to prevention of information blocking attestation statements under the Promoting Interoperability program as part of that first public reporting component of this rule. And then CMS is also requiring that providers maintain digital contact information in the NPES system and will be reporting providers that do not comply with this rule. So these first 2 components, provider focused, technically in effect now, though, again, Brad will cover a little bit more details here in the next coming slides. So then the second requirement for providers to be aware of is specific to admit, discharge, and transfer event notifications. So in order to improve care coordination, hospitals with EHR will be required under this rule to alert providers when their patients are admitted, discharged, transferred, or receive any services within the emergency department. On the health plan side, there are requirements for both patient access APIs to be created. For the patient access API, health plans will be required to make claims and encounter information available to a member via a third-party application of their choosing. And then for the provider directory API requirements, health plans are required to make provider directory information publicly available via a standards-based API. Lastly, on the health plan side, there is a requirement that goes into effect on January 1st, 2022 for health plans to exchange certain patient clinical data at the patient's request, allowing a patient to take their information with them as they move from one payer to another over time to help them create a more cumulative health record with their current payer, as Mike mentioned as some of the goals for this rule. The 7th component of the interoperability and patient access final rule is actually focused on improving the dually eligible experience. And they have updated the requirements for states to exchange certain enrollee data for individuals that are dually eligible for Medicare and Medicaid from monthly to daily to improve the overall Medicare, Medicaid dual beneficiary experience. And so to drill in a little bit further on what each of these rules require specifically for health plans, I'll talk through each of these a little bit further, and then I'll pass it along to Brad to cover some of the provider focus policies in a little bit more detail. So for the patient access API, which the enforcement date will be 7/1/2021, this is really focused on establishing an API that allows a health plan's members to access their health information via a third-party app. Some of the scope of data required by this rule will be focused on providing claims and encounters, including provider remittance and enrollee cost sharing to the patient, as well as clinical data if maintained by the health plan, and that does include lab results. For Medicaid or Medicare Part D plans, they will also need to be prepared to share formularies and preferred drug lists, as well as covered drugs and any tiered formulary instruction or utilization management procedures with their patients as well. There are technical standards that are required as part of this data sharing. CMS 9115F does require for the patient access API the use of FHIR and USCDI core, as well as they have some specific technical standards for authorization and authentication of the third-party applications as well. Specific to timing, notes to be aware of if you're a health plan, this information must be provided to the member no later than 1 business day after a claim is adjudicated or an encounter received, and it will require available history from 2016 onward. So as a health plan preparing to comply with the patient access API, you'll need to think about what are all the data sources that you'll need to be using to grab information to send a comprehensive look back to the client or to the member. For the second requirement, a health plan does need to make provider directory information available via an API, and this will include provider name and network status, address, phone numbers, and specialties. And if you are part of Medicare Part D, pharmacy name, type, and contact information as well. The technical standard required for this API is also FHIR 4.0.1, and then the timing for which is required to be 30 days of receipt of any new data or changes to your existing directory data. And last but not least, on the health plan side, there is a payer-to-payer data exchange, which requires that the members request to exchange clinical information, primarily the USCDI data, to the new health plan at a member's request. And this is also going to be requiring history about a member from 2016 onward. Brad, do you want to cover some of the provider-specific requirements?
Yeah, no, let's jump in here. So, you know, as Heather discussed in the brief history and some of the snapshot slides, there's, you know, a historic and current list of related initiatives, organizations, legislature that have really brought us to the specific items on this slide, and that are in the actual final patient access rule, which is really the key topic of today's discussion. I think it's important to call out that there are definitely related policies that are specific to providers that we're going to find in things like the ONC's 21st Century Cures Act that provide some additional definitions and frameworks that are related to these. So that's one item that we'll call out toward the end of this webinar, just on how important it is to stay up to date on those related items in the healthcare landscape for additional guidance and policy. So with that in mind, you know, let me walk down this list. So Heather touched on a couple of these at a high level, but as it relates to the first policy here regarding public reporting and information blocking, and this item specifically requires providers to attest to 3 information blocking statements for CMS's merit-based payment system, or MIPS. It applies to all eligible clinicians, hospitals, and critical access hospitals participating in the Promoting Interoperability program. And if we take a look at those statements and break those down, the first statement's really just requiring healthcare providers to demonstrate that you didn't knowingly or willfully take action to limit or restrict, you know, compatibility or interoperability with your electronic health system record system. That second statement builds on the first and focuses on how you've implemented that system. And then the third focuses on how you've actually used that system. So by attesting to statement 3, you're really just confirming that you've acted in good faith to use your system to support, you know, the appropriate exchange and use of health information. Those who respond no to any of those 3 statements would then be publicly reported by CMS, as Heather touched on in the timeline slide. Initially, the reporting was to be released in late 2020, which is why you saw the asterisk on the slide. Since then, the compliance date has been updated to April 5th, 2021 on this. So TBD on when we'll see reporting actually released in relation to that. And it's also worth noting that for this specifically as well, the OIG has proposed a definition of a violation to clarify how they would determine information blocking practices. So there's some definitions of like 8 different exceptions and things of that nature that's defined again in that Cures Act and other related legislature that would result in a civil monetary penalty fine. And then also just how do they determine the basis for imposing those CMPs and determining the amount of penalty imposed. The second item here is relating to that digital contact information. So in essence, the provider needing to maintain that detail in CMS's National Plan and Provider Enumeration System, or NPES. And this, again, applies to all healthcare providers, facilities, or practices, as well as to commercial plans, who own and manage provider practices that see Medicare patients. So when we think about what that digital contact information looks like, this is specific to providing details such as a provider's secure digital endpoint, like a direct address or a FHIR API endpoint. And NPES can be updated with that endpoint information when a new MPI is requested or an update to an existing process. Similar to information blocking, the CMS had initially announced that they would be publicly reporting those not in compliance in late 2020. So that list hasn't come out either. So there's some details around accumulating a more comprehensive report before details are released there. And I think really at the heart of this policy is just to encourage and enable providers to utilize the secure contact information to facilitate some of that care coordination that Mike alluded to on the first slide with the new exchange of data and accessibility. And then finally, the third policy here around ADT event notifications is applicable to providers, at hospitals, psychiatric hospitals, as well as critical access facilities. And for these, if we drill into this a little bit more, it's really just providing notification to a patient's primary care provider or folks like a post-acute care center that need to know what's going on with their patient. So if we look at this specifically, there's a couple of different conditions that a hospital needs to meet. The first is that they have a fully operational notification system that's compliant with state and federal statutes, regulations to really securely exchange that information. Second, it's to send a pretty trimmed down list of details. So at a minimum, it's the patient name, the treating practitioner, the sending institution. Optional data could include diagnosis detail, but that's also dependent on state and what's allowed by law. And then additionally, the hospital is required to physically send that notification from that approved system to the providers that the patient has given them as the primary responsible for the care. So I think one thing to note with this is for instances where a hospital can't identify a primary care practitioner or post-acute provider for a patient, CMS doesn't expect that an ADT event notification would be sent in those cases, but they do require that a hospital must be able to demonstrate that it's made a reasonable effort to ensure notifications are sent and received where applicable. The compliance date for this one is fastly approaching. It's May 1st, 2020. So providers found in non-compliance can risk CMS denial of payment and other possible sanctions.
So there are a number of resources that, regardless of whether you're a provider, a health plan, or elsewhere within the industry, that you can use to really get started on scoping out and determining the requirements for compliance with any of these rules. First, to start with technical standards. So there are 4 main technical standards that these rules will require. HL7 FHIR 4.0.1 is the latest version of the FHIR resources, which define content and structure of core health information. And this can be used by developers to build standard applications. It requires health plans, providers, and the app developers to use the same data standard. USCDI is U.S. Core Data for Interoperability, which is a set of health data classes and component data elements that are used for nationwide interoperable health information exchange. This is where you're going to see a lot of the clinical requirements coming into play, and both of these data standards have detailed mapping documents and implementation guides out there. Smart IG OAuth 2 is focused on the authorization component of the API rules. This will provide reliable, secure authorization for a variety of app architectures using the OAuth 2 standard, and it will enable third-party apps to request authorization to access a FHIR resource and retrieve that resource back. And then OpenID Connect is the authentication layer built on top of the OAuth 2 protocol that enables clients to verify end-user identities and obtain basic profile information from claims data in an interoperable manner. So these are the technical standards that you will need to be aware of and be prepared for. But to help you get there, there are implementation resources that CMS has provided, as well as there are a number of private innovators in the healthcare community looking to expand the use cases for these specific data sets and technical standards. So just to quickly provide an overview on what implementation resources are available, CMS has pretty robust information on patient privacy and security resources, as well as best practices for payers and app developers that are working to tackle these requirements. And then DaVinci has developed a number of implementation guides as part of they're a private effort to accelerate the adoption of FHIR resources. And then last but not least, Karen Alliance is a HL7 FHIR accelerator program, which has built an implementation guide for Blue Button capabilities that are issued by CMS. And then looking over to how can an organization implement the technology that they are going to need as part of these rules. So once you have information about the technical standards and implementation resources, there's a number of sample market solutions available that you may want to consider. So there's Azure API for FHIR, FHIR works on AWS. Some of the big box players offer platform as a service for the API development, as well as there's some niche healthcare companies, whether you're a health plan looking to engage with a vendor to help you meet these requirements, or if you're a provider, there's a number of the big EHR vendors that can plug in for the requirements, such as the ADT notifications that Brad described earlier. So, know your options. There are options out there, and we are happy to answer any questions that folks may have on this page as well. And then just one more helpful resource for this audience. There is My Health application, which is being managed by the Karen Alliance, that lists health applications that have digitally connected to providers, hospitals, and health plans around the United States. So there's a lot of good information on this website that you see on the slide that can kind of help you learn more. Brad, back to you.
Awesome. So, just to kind of run us back to where we're at now, we've gone through what's been the landscape, both current and historical. What are the actual policies themselves? Heather walked through some great resources to start. So you guys are probably ready to leave. But before we do that, let's go through maybe and pause and look at how to think through and dive deeper into how to maximize maybe some return on investment on this implementation that you're required as a payer or as a provider to do. So when you think about the lift required for your organization to be compliant, the resources to be involved, and then the assets that you'll have to develop, there's a broad range of use cases that can really be supported by your interoperability investment. and the implementation. And this is, where you guys live day to day. So I'll try to walk through these and give some examples, but these are things that should be readily familiar with from your normal business operations. But I think as we see these, it just shows the importance of taking that step back and thinking beyond, strictly compliance. If we think back to that initial polling question of how to get that additional value for your organization. So we look at the first use case here. It's specific to identifying and targeting patient care gaps to improve quality measures, risk adjustment stars that you as an organization might not have otherwise been able to get to through this additional transfer and accessibility of data. So really the point here is just it's critical to identify how can we plug in new data into downstream processes, such as gaps in care. So if you're now getting a member's prior history from their past payer, you see to have a health screening that may remove a gap that you no longer have to focus on and just leads to more efficient operations that you guys can focus and spend time elsewhere where you need to. The second is just really looking at how can we drive care management programs. So again, using this additional data, the standardized format required to pull from disparate systems, we could really inform care management processes to help facilitate better, more proactive care that results in reduced costs for payers, providers, and really patients alike, as well as improving those care outcomes. And then I think this also ties into facilitating value-based care arrangements that often hinge on that holistic view of the full patient episode and where they're at in the continuum of care. The third use case here really thinks about consumer outreach approaches. So now that you have this API allowing patients or members to access their health information, you have the opportunity to really change and evolve the overall member experience. So how could you engage, connect with them as a healthcare organization as you manage their user and contact details? This may lead to some questions about how to better target outreach and really how to just build and establish improved relationships and trust with those members. The fourth just centers around data management, which is going to be critical with all of the data that's involved here, specifically with provider data management, understanding the actual requirement to publish that provider data directory in a FHIR format. How can you look to use this to reinforce efforts to make sure that core provider data management and directories are accurate? Because that's going to be critical for just your normal business processes with the accuracy of that data. And then the fifth bullet point, I think this is really just a foundation and a jumping off point for future data sharing and collaboration. So as we can see from these sampling of use cases and their benefits, there shouldn't only be incremental growth in the actual physical sharing and acquisition of data, but also in that collaboration and trust among parties involved as they kind of experience and observe the benefits of what's going on as interoperability continues to progress. So these are just 5 examples of how to maximize the ROI on these implementations by thinking proactively and by taking a more strategic approach and lens to the compliance efforts. So with that, I will pass the ball back over to Mike to talk through some implementation success enablers.
Thanks, Brad. Okay, so this takes us to the fourth and final part of the agenda at the beginning. So, what are some of those, those tactical recommendations we have, right? Those based on our experience, helping organizations achieve compliance or deliver projects around the subject matter. How do we get some success, in getting the work done? On the first comment, Heather's slide a little while ago with OAuth 2 and FHIR 4.0.1, right? There's a lot of technology involved in this, but technology is not the only element, of being successful, right? So that first point on the page, we're thinking about things like, your regulatory compliance teams, making sure we've got, every detail covered in our organization's journey towards compliance. We've got member communications, opportunities here. We've got maybe some business teams that are seeking some of those larger value points that come out of, the stuff that Brad just talked through, as a whole set of considerations you might have on your plan. And so this phrase, a comprehensive strategy that considers, both business enablement and operational readiness in addition to technology, we think focusing on all of those factors is an important factor to success. Right? Making sure you've got the operational readiness teams, the customer engagement teams, the compliance teams, and the technology teams, all working in harmony towards the goal of the deliverable. On point two there, Brad did a nice job setting up some some value prop beyond achieving compliance on the previous page. I would call out, in addition to those process benefits that Brad was describing, the ways different functions in the organization, the patients and members themselves, can use this information to gain other value points. A little bit more tactically during implementation, I'd also say that underlying those 5 bullet points that Brad talked through is largely sort of the same data asset, right? So the data, required to be brought together to pump into the interoperability requirements is often, we think, the same data that's required to go after those, those strategic value points that Brad was talking about. So in your tactical implementation plan, having a sense for thinking about what other strategic business benefit you might gain from the investment in the implementation, thinking about that as you're driving the core compliance implementation, we would think helps you get the right architecture, gets the right scope, gets the right identification of source systems and the right profiling of those data assets, right? Getting everything together robustly at the beginning, to focus on the result of compliance, but also to build that future platform that may have value to other initiatives your organization might tackle on top of the foundation laid down via interoperability. We're all about the work plan, right? There's a large number of activities to accomplish, to bring this stuff together. So making sure that we know, what activities we need to execute across all those different stakeholder groups, across different technology stacks, whether they're source systems or data assets or new FHIR infrastructure coming into the organization, whether it's a little bit of member engagement and operational readiness team members along with the technology team members, right? I mean, bringing all those people together under the headline of an umbrella plan. I think again, brass tacks and tactical a little bit on the slide, but a critical factor in achieving successful delivery. Point 4 on the right hand side of the page, I think ties pretty well to point 1 and point 2, but just making sure that we've got alignment between both the technology strategy and the business strategy, that those things are working harmoniously with each other as we're forming these architectures and developing these work plans. And then the fifth point maybe is a little bit different. Let's make sure we get value out of what we're building, right? So I think it's a great opportunity. Most organizations have some version of a patient or member experience program, right? There's a whole spectrum of things that organizations are doing, in those engagement programs, ranging from, the minimum to meet compliance to more proactive, sort of trying to drive behavior type of engagement programs and everything in between. We just think that this requirement is a great opportunity to do some planful communication, with your customer populations, members, if you're a health plan, or patients if you're a provider, the opportunity to get in touch with them, to tell them that your organization is going to be compliant with this mandate, the value that you think they can get from it, the tactical advice on how to connect to it. Taking this as an opportunity to engage, with the customer base, drives a little bit of that goodwill that the customer engagement programs are generally seeking to drive, and it also may drive a nice population of users, to the capability you're building. So we would definitely recommend making sure that proactive customer engagement is part of your strategy. And then back to the work plan. You got to staff the plan in order to deliver the results, right? So as you've identified those resources necessary to get the work done, we do think this is a big investment. CMS has estimates out there as to what they think it will cost an average organization to be compliant, and those numbers aren't necessarily small. And organizations are investing in this today, so make sure the plan is backed up by the resources necessary to get you soup to nuts through delivery. All right, so again, we just wanted to leave you with some thoughts we had on implementation success. So we just wanted to summarize some key takeaways, right? We drew a few points here from across all 4 sections of the agenda. So if you take away a few things from the conversation, bring it back to your organization and how to further that progress that we saw on the polling question number 2 inside of your organization. Here's what we think is sort of the most tactical or most actionable from what we've talked about. that there is a ton of resource information out there. Heather did a nice job of naming some of the big ones. Those implementation guides I find to be particularly helpful. You got to have the patience for 30, 50, 100-page PDFs, when you start opening those things up. But there are lots of members of the community who have invested significant time, CMS not the least of them, in developing these implementation guides. And when we get into the HL7 community, there's a lot of information, available as well, from that community that is directly related to implementation here. So use the resources that are in the deck. Morgan will get this out to all of you within a few business days of the presentation today. And, you can search beyond, from that starting point, but you'll find tons of information available and certainly rally around, those resources. There's lots of choices from a technology architecture perspective, right? And Heather touched on that too on that same page. She talked about some of the big cloud vendors, delivering some platform as a service components that might be relevant in your environment. Some of the core technology vendors that already serve the industry have built some functionality into their applications, and then there's some niche boutiques that are launching as well that have specific solutions that focus specifically on this problem. So consider your current state, consider the architecture you have in place today, and where you need to complement or augment your current solution to bring pieces together. You got lots of choices. There's lots of solution paths available, but one of those will be right for you given the amount of diversity of solution available in the market. So consider those different types of options and which is best for you. We like back to the original intent of the regulation, right? We really like that, thinking beyond compliance, right? We don't want to look at this just from a check the box activity to comply with the regulators, but those care management programs, those value-based care relationships, those member engagement programs, right? All those things need the same data that you need to wield to be compliant with interoperability. So to the extent you can, take advantage in your organization of the investment you may be making for compliance to drive the adoption of some of those other programs. Again, back to the tactical work plan, and we just talked about that on the previous page. Make sure you've got a plan to deliver this thing. It is complicated. We think there are many stakeholders likely involved, and we think that there are many layers of the technology likely involved. And so, bringing that all together, in a plan, will help you get across the finish line. And then the last point here, as we evidenced a little bit, with the timeline picture showing that there were many rules that came before the one in question today, and rules already proposed in the future, you got to keep a pulse on this stuff. The proposed rule documented here, the 9123 in proposal state, that rule is about prior authorization for the Medicaid population, but in the proposal, there's contemplated rule changes to 9115 that we were talking about today, where the payer-to-payer exchange that Heather talked about currently doesn't require FHIR. In that 9123 proposal, there's thought of I'll say upgrading, but you guys can choose your favorite word there, upgrading the technology platform for 9115 for payer-to-payer to FHIR. So these things Brad did a good job of describing this. All these things sort of reinforce each other. There's lots of cross-references back and forth between the rules, and as new rules come out, sometimes they are refactoring components that were previously introduced in a prior rule. So you got to stay on top of this stuff because the landscape is fairly regularly evolving. So hopefully those 5 things are some crisp takeaways from the 50 minutes. All right, thank you, everybody.
Thank you, everyone.